അഖില നമ്മുടെ ഡോക്ടർ കിരണിന്റെ പേര് കണ്ടായിരുന്നു. എല്ലാവരും ഒരിടത്തു നിന്നാണോ ഒരു 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 ലാപ്ടോപ്പിൽ നിന്നാണോ എല്ലാവരും ജോയിൻ ചെയ്യുന്നത്? ഒരു ഡിവൈസിൽ നിന്നാണോ ജോയിൻ ചെയ്യുന്നത്? ഡോക്ടർ
അല്ല
അഖില
സർ,
എല്ലാവരും ഒരിടത്തു നിന്നാണോ ജോയിൻ
ഡോക്ടർ
ചെയ്യുന്നത്?
ഡോക്ടർ
രണ്ട് സ്ഥലത്തു നിന്ന്?
വേറെ ലാപ്ടോപ്പിൽ നിന്ന്, ഞാൻ
ആ
വേറെ ലാപ്ടോപ്പിൽ നിന്ന്.
ശരി. കിരൺ അല്ലാതെ ഒരാളും കൂടെ ഉണ്ടല്ലോ. ഗുഡ് ഈവനിങ് പത്മനാഭ സർ. ഒരാളും കൂടെ ഉണ്ടല്ലോ, അതാരാണ്? ഡോക്ടർ
ഡോക്ടർ
കിരൺ
ദിവ്യയും
അല്ലാതെ
കിരണും ഒരുമിച്ചാണ് സർ.
ഡോക്ടർ ദിവ്യ ഇതിനകത്ത് പേര് കാണുന്നില്ലല്ലോ. രേഖ മാഡം, ഗുഡ് ഈവനിങ്.
അഞ്ചു
സർ,
നമ്മുടെ
നമ്മള്
യൂട്യൂബ്
ഒരു
സ്ട്രീമിംഗ്
PPT സർ പ്രസന്റ് ചെയ്യുന്നത് മർജ് ചെയ്തിട്ടുണ്ട് PPTs രണ്ടും.
ഓക്കെ 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 ശരി ശരി. അപ്പം പ്രസന്റ് ചെയ്യുമ്പോഴത്തേക്ക് വീഡിയോ ഓൺ ചെയ്ത് നോക്കുക. ഈ പറഞ്ഞ പോലെ എന്തെങ്കിലും ഒരു വീഡിയോ ഇഷ്യൂ ഉണ്ടെങ്കിൽ മാത്രം വീഡിയോ കട്ട് ചെയ്താൽ മതിയാവും. അഖില ഓക്കെ അല്ലേ? നമുക്ക് തുടങ്ങാമല്ലോ അല്ലേ?
സർ ഓക്കെ സർ.
എല്ലാവരും ജോയിൻ ചെയ്തിട്ടുണ്ട്. ഓക്കെ ഓക്കെ. ശ്രീജിത് സാർ നമുക്ക് സ്റ്റാർട്ട് ചെയ്യാമോ? പത്മനാഭ സാറും ജോയിൻ ചെയ്തിട്ടുണ്ട്, രാംകുട്ടി സാറും ജോയിൻ ചെയ്തിട്ടുണ്ട്.
Yeah, we can start, I think.
യാ. ഡോക്ടർ ശ്രീജിത്ത് കേൾക്കാമോ? ഡോക്ടർ ശ്രീജിത്ത്?
yes, it's audible.
Okay. Okay. A very good evening to all, and a hearty welcome to the next episode of Journal Club of Trivandrum IAP. Today we have a very interesting session on ventilation of pneumonia in children, and the team is from Gokulam Medical College, and we have Dr. Akhila Nas. Madam is the Assistant Professor of Pediatrics at Gokulam Medical College as the mentor, and Dr. Divya Pradeep and Dr. Kiran Krishna T. Dr. Divya Pradeep Madam will be presenting the paper, and analysis will be done by Dr. Kiran Krishna D. Both are JR Pediatrics. And before starting the session, I would like to hand over the mic to Dr. Srijit Kumar, IAP Secretary, Tirunelveli. Over to Dr. Srijit, sir.
Thank you, Anju, for the guest. And first of all, being sorry for I'm not available for this meeting over the full time because I'm traveling. And so we'll continue this academic program of Journal Club for the last several months. And we are very happy that the Anju and team is conducting this program regularly to have to make our members enable to make evidence-based choices for the daily practice. So continue your good work. Thank you, Anju Kanmani, for and Padmanabhan sir and Amguti sir for the wholehearted support for this program, and also the presenters and over to you. We are looking for the academic solution. Thank you, Anju.
Thank you, Dr. Srijit, sir. We have Dr. Ramkuti sir, Emeritus Professor, SCT IMST, as the expert analyst, and Dr. Padmanabhan sir, Senior Consultant of Pediatrics in PRS Hospital, as the coordinator of the Journal Club. And we will be joined by Dr. Rekha Isnar Madam, the Senior Faculty Gokulam, has already joined, and we are expecting Dr. Elitha Kailath Madam too. Once again, a warm welcome to all, and we will be starting the session. Shall we go for the presentations, Dr. Padmanabhan sir?
Yeah, please go ahead with the presentation.
Okay, thank you, sir. Over to Dr. Akhila Naz. Any opening comments, Dr. Akhila Madam?
Yes, thank you, sir. Good evening, everyone. Thank you, IAP Trivandrum, for this opportunity. So the study we are discussing today is a meta-analysis on the comparative efficacy of bubble CPAP over low-flow oxygen therapy in children with severe pneumonia in low-resource setting. So CPAP needs no special introduction. We all use CPAP for treating pneumonia. So in addition to providing the oxygen, it also splints the airway, it recruits the collapsed alveoli, and there are many such advantages. So CPAP can be given by ventilator, which is not readily available. So we have to resort to bubble CPAP. So that again can be delivered by commercial machines or by the indigenous setup with the plastic bottle and water. So in resource limited settings, they still use these modalities to treat pneumonia, especially when there are no physicians or advanced ICU care in these scenarios. And there is also certain local myths that interfere with the use of respiratory support for treating pneumonia. But in a scenario like ours, where there is respiratory support with ventilator and ICU in almost all the hospitals, where does this bubble CPAP stand? I think we all still use bubble CPAP. and it is much less expensive than the newer modalities like HFNC. And we have also recently witnessed our COVID pandemic when we have exhausted all the other modalities. So in such scenarios also, we have to resort to the much maybe less desirable but much wanted bubble CPAP support. So that is the significance of this bubble CPAP in current scenario. So over to the presenters for the study. Thank you, sir.
Thank you, Madam. As Madam has rightly pointed out, since it is a major community problem, this pneumonia is, and post-COVID, we have even the public healthcare as well as corporate medical colleges, hospitals are having most of the newest modalities of treatment and all. So it will be worthwhile for the pediatricians to know more about the point of ventilation and the details of ventilation, the indications and the details like that. And over to Dr. The presentation today is done by Dr. Divya. Or to Dr. Divya. Then starts the sharing the screen. Yes, madam, the screen is visible. You can start the presentation.
Good afternoon. I'm Dr. Divya, junior resident from Sri Gokula Medical College. So today we are presenting a journal. With the title, Effectiveness of Bubble CPAP for Treatment of Children aged from 1 to 59 months with severe pneumonia and hypoxemia, a systematic review and meta-analysis of randomized controlled trials. So the study is published in Indian Pediatrics, Volume 62, June 2025. It is also indexed in PubMed. This is a systematic review and meta-analysis consisting of 3 randomized controlled trials taken one from Bangladesh. It is Chishti et al. From Malawi. It is McCollum et al. And from Ethiopia, it is Gabri et al. Authors of the study are Mohammad Tanshad et al., who are from Jordan, USA, and Poland. Coming to the abstract, the objective was to use bubble CPAP in children with moderate to severe respiratory distress in developing countries. It is simple, cost-effective, less invasive, and an alternative to CPAP. And the meta-analysis aims to compare the effectiveness of CPAP with low-flow oxygen for severe pneumonia and hypoxemia in children. And the methods, web search was done from PubMed, Embase, Cochrane Library, Web of Science and Central. And the trial was reported up to March 23, 2024. And the outcomes were reported as risk ratio, mean difference and confidence interval using a review manager software, and a p-value of less than 0.05 was considered statistically significant. And the results from the 3 RCTs consisted of 2030 patients, and the result was there was no significant difference between bubble CPAP and control in overall mortality, death during hospital stay, the composite primary outcome, pneumothorax, and leaving hospital against medical advice and length of hospital stay. The conclusion was significantly fewer events of severe hypoxemia and less requirement of mechanical ventilation was found, but bubble CPAP is not superior to low flow oxygen for improving the survival and reducing hospital stay. Coming to introduction, pneumonia is a leading cause of mortality among under 5 children, especially in low to middle income countries. An estimated 740,000 deaths were reported globally in 2019. Hypoxemia significantly escalates the risk of mortality in children with pneumonia and underscores the needs for effective respiratory support interventions. So CPAP is a standard treatment for children with moderate to severe respiratory distress in developed countries, but it is via mechanical ventilator. But it is unavailable in most of the developing countries. An alternative for this is bubble CPAP. It is low cost, less invasive, potentially applicable in low resource setting. And the bubble CPAP method involved connecting the expiratory limb to a breathing circuit to a tube submerged in water. And the pressure generated in the upper airway corresponds to the depth at which the tube is submerged. And but despite being a good alternative, there is a lack of comprehensive comparison of bubble CPAP versus low-flow nasal cannula in managing severe pneumonia. So hence this meta-analysis aims to assess the comparative efficacy of bubble CPAP and low-flow nasal cannula in children with severe pneumonia and hypoxemia in low-resource settings. So the aim of the study is to synthesize findings from multiple studies conducted in resource-poor setting to assess the comparative efficacy of bubble CPAP and low-flow nasal cannula oxygen therapy in reducing treatment failure or mortality in children with severe pneumonia. And the method was for protocol registration was finished using PRISMA statement and Cochrane handbook and was registered into Prospero. Prospero is an online database where we register the protocol. And data source and strategy was taken from PubMed, Scopus, Web of Science, Embase, Cochrane Central Register of Control Trials, and the searches were until March 23, 2024. And the search words were continuous positive airway pressure, bubble CPAP, CPAP, children, pneumonia, oxygen deficiency, etc. Eligibility criteria was the population of children aged from 1 to 59 months with severe pneumonia and hypoxemia. Intervention was bubble CPAP. Comparator was low flow oxygen. Exclusion criteria was trials including non-human and in vitro experiments, studies that are overlapping a duplicate database, book chapters, reviews, comments, letters to editors and guidelines, and studies that are not published in English language. And the primary outcome of this meta-analysis was a composite primary outcome of treatment failure defined as per individual study. For example, severe hypoxemia with a saturation of less than 85%, signs of severe respiratory distress, indication for mechanical ventilation and or death, and then overall mortality, death during hospital stay. And the secondary outcome was length of hospital stay, pneumothorax, leaving the hospital against medical advice. The selection process was done by Covidence tool. It is a software used to manage the screening and selection process. So from the search databases, about 1,845 citations were taken. Out of this, 1,326 citations were removed as duplicates were found. And from the remaining 519 studies, 511 studies were again excluded, and the remaining 8 studies were thoroughly read. And from that, only 3 studies were taken for the RCT, as it was only meeting the eligibility criteria. After selection, finally 3 studies met the eligibility criteria, and a total of 2,030 patients were taken. All these were open label studies. And coming to data extraction, after acquiring the complete text from the pertinent publication, a pilot extraction was done and is made into an Excel sheet which consists of 3 sections, and 2 reviewers were responsible for the data extraction, and disagreements were resolved after discussion with the senior author. And coming to the assessment of bias, Cochrane ROB2 method was used to assess the risk of bias under 5 domains, and the 5 domains were measuring the outcome, selecting the reported results, deviating from the intended intervention, missing outcome data, bias related to the randomization process. 2 reviewers independently assess the quality of the studies. And this is a traffic light plot diagram which indicating the risk of bias, out of which the Chishti et al. Study showed high risk of bias in the measurement of outcome. Analysis part. It was conducted using Review Manager software 5.3, deployed the random effect model to accommodate a larger standard error in a pooled estimate. And they have calculated risk ratio and confidence interval for the binary outcomes. And for continuous outcome, they have calculated mean difference and confidence interval, and a p-value of less than 0.05 was considered statistically significant. They used a pairwise deletion for missing variables. Coming to the analysis part, for the overall mortality, they have estimated a risk ratio of 0.46, which indicate there was a 54% of reduction in mortality with the use of bubble CPAP, but the confidence interval they had calculated was wide, which is crossing 1, and the p-value was also insignificant. So the overall mortality rate was interpreted as statistically insignificant. Likewise, for death during hospital stay, they have calculated risk ratio 0.48 with a wide confidence interval and a p-value of insignificance. So that was also considered insignificant. Likewise, for composite primary outcome, the statistical data was insignificant. And pneumothorax also, the risk ratio was more than 1 and it was statistically insignificant. For living against medical advice, the interpretation was not statistically significant. And for length of hospital stay, the outcome was not statistically significant. But in case of severe hypoxemia, the risk ratio was 0.22 and the confidence interval was narrow with a significant p-value, which indicate that there was about 78% improvement in severe hypoxemic events with using bubble CPAP. Hence, it was a statistically significant data. And likewise, in mechanical ventilation also, there was around a 67% of reduction in need for mechanical ventilation with the use of bubble CPAP. So with the 3 RCTs, to assess the heterogeneity, they have used chi-square test. And using the chi-square test, they have calculated I-square and p-value. A p-value of less than 0.01 was considered significant, and I-square value of more than 50% was indicated to have high heterogeneity. So using the chi-square test, they have calculated the I-square, and I-square for outcomes such as overall mortality, death during hospital stay, composite primary outcome, and length of hospital stay was more than 50%. Hence, they showed a significant heterogeneity. And the outcome like severe hypoxemia, mechanical ventilation, pneumothorax, and living against medical advice showed a low heterogeneity. That is, the I-square was less than 50. So coming to the forest plot diagram, in case of overall mortality, the estimated value from the study was mentioned as the diamond plot, which is crossing the null point. So this data is statistically insignificant. Likewise, in case of death during hospital stay, the diamond is crossing the midline, that is crossing the null point. It is again statistically insignificant. But in case of severe hypoxemia, the diamond, that is the estimate, is favoring more towards the bubble CPAP region. Hence, it is a significant outcome. Likewise, in case of mechanical ventilation also, the diamond is not crossing the midline. Hence, it is a significant data. But in case of composite primary outcome and length of hospital stay, the pooled estimate is crossing the null point. Hence, both are statistically insignificant. So to deal with heterogeneity, they have further done sensitivity analysis for some of the variables. So it is done by leave-out method. That is, they will eliminate one of the study. They will vomit out one of the study. For example, in case of overall mortality, they have eliminated McCollum et al. Study and recalculated the outcome, which showed a heterogeneity of 0%, which indicate that the McCollum et al. Study is a contributing factor for heterogeneity in the meta-analysis. Likewise, in composite primary outcome, they have eliminated McCollum et al. Study and recalculated the heterogeneity with the other 2 studies, and which indicates that McCollum et al. Study is the contributing factor for heterogeneity in composite primary outcome. Likewise, in case of length of hospital stay, the Gebri et al. Study is eliminated and recalculated the outcome with the other 2 studies, which indicate that Gebri et al. Study is the contributing factor for heterogeneity in case of length of hospital stay. But with these three parameters who were earlier statistically significant is suddenly becoming significant with eliminating one of the study. But this kind of an outcome, we cannot consider it as consistent. So coming to the discussion part, the children with bubble CPAP experienced significantly fewer events of severe hypoxemia and required less mechanical ventilation, and the need of mechanical ventilation was reduced by approximately 62%, and the events of severe hypoxemia by 78%. And the findings indicate there is no significant difference between bubble CPAP and control regarding overall mortality, death during hospital stay, composite primary outcome, pneumothorax, leaving the hospital against medical advice, and length of hospital stay. But the analysis revealed high heterogeneity. After addressing heterogeneity, the results were inconsistent. Inconsistent results were primarily derived from 2 remaining studies in the sensitivity analysis. Hence, that indicate that further investigation is needed. So the strength of this meta-analysis is that this is the first meta-analysis on the topic, and it is taken from multiple settings where a small intervention can be life-changing. Coming to the limitations of the study, this analysis included only 3 studies, so it limits the generalizability of the findings, and it showed a high heterogeneity, which required sensitivity analysis, but it is only based on 2 studies with lowest numbers of patients. Hence, it reduces the strength of the evidence, and analysis from the pooled data from different studies, each with inherent limitations, and all 3 studies are taken from different countries, which is having a varying comorbid profiles. So coming to the conclusion, bubble CPAP is not superior to low flow oxygen when considering survival or a hospital stay, but reduces severe hypoxemia and decreases the need for mechanical ventilation. Bubble CPAP is a useful supportive therapy, especially in resource-limited setting, but future studies with large population follow-up may be needed for validity of these reported outcomes.
Okay, thank you, Dr. Divya. It was an excellent presentation. Over to Dr. Kiran for the analysis.
A warm good evening to everyone. I'm continuing with the critical analysis. I'm Dr. Kiran, junior resident from pediatrics from Sri Gokulam Medical College. First, let me discuss on PRISMA 2020. It's a reporting guideline for systematic reviews and meta-analysis. It's a revised 27-item checklist and along with its expanded guidance. So for the ease of it, I've described all the 27 items checklist on the top of the slides with its expanded guidance. First one is title. The title explicitly includes both systematic review and meta-analysis. Abstract itself has a 12-item checklist, of which 7 are satisfied. It has been identified as a systematic review or meta-analysis, background or rationale, objectives, information sources, participants and interventions, results, main outcomes, and interpretation and conclusion are clearly being stated. Although eligibility criteria, it mentions RCTs but lacks details on inclusion and exclusion criteria in the abstract. Coming to the study appraisal and synthesis methods, meta-analysis is mentioned, but risk of bias assessment not described. Limitations, registration, and funding or conflict of interest has not been mentioned in the abstract. Next is introduction. Introduction has been mentioned in 2 parts, that's 3 and 4. First, rationale. Rationale is well written and identifies the existing gap and need for synthesis. The 4th one is the objective. It's clearly represented in PICO format. Although the population is mentioned as the children with severe pneumonia, the age group has not been mentioned. Coming to methods. Methods have been described from items 5 to 15, which will be discussed. First one, eligibility criteria. Inclusion and exclusion criteria have been clearly defined. Although when coming to grouping for synthesis, all included RCTs were pooled into a single meta-analysis. No subgroup analysis or sensitivity-based grouping, which limits exploration of heterogeneity. Next is information sources. All databases used are clearly listed. Date of last search was specified. When coming to other sources, trial registries, great literature sources, websites, organizations, etc. were not clearly described in the study. Next is search strategy. A detailed Boolean string is provided, but there is no mention of any filters or limits used. Coming to selection process, number of reviewers, if it's an independent review or not, discrepant resolution, automation tool use, and the details of how many records screened by each reviewer has been clearly mentioned in the selection process.
Next, when coming to data collection process, number of reviewers, data extraction tool, pilot testing, discrepancy resolution method, and automation tools have been clearly mentioned. Although when it comes to if the reviewers worked independently or not, and verification with study authors for the missing data, there is no clear description was given. Next is data items, which has been given in two parts. And coming to 10A, it expects Prisma. Here the Prisma expects the outcomes for which the data were sought. Outcomes were listed and meta-analysis did not provide definition for each individual outcomes due to and it did not state whether the measurement definitions or all analysis compatible with each outcome. Due to variability of data, no clarity as to which all results were collected is also not mentioned. There is no clarity as to which all results were collected. Next, coming to 10B, here Prisma expects the variable to define all the variables for which the data was sought. The study characteristic, participant characteristics, intervention or comparator details, funding source, and handling of missing data has been clearly study characteristics, participant characteristics, intervention, comparative details, and funding has been clearly mentioned. Although when it comes to handling of missing or unclear data, a pair deletion is mentioned, but there is no clear assumption of missing or unclear data. Next is study risk of bias assessment. Tools used is clearly stated. Domains, number of reviewers, if they worked independently or not, disagreement resolution method, automation tools, and risk of bias has been clearly stated in the study. Coming to effect measures. Effect measures is specified for each outcome. Relative risk for binary data and binary outcomes and mean deviation for continuous outcomes. A 95% confidence interval is used throughout. Next is the synthesis methods. It's described in in 7 parts. The first part, here the Prisma expects to decide which describe the process used to decide which studies were eligible for synthesis. The process of determining the study eligibility, characteristics of included studies, and the flow of the study inclusion and exclusion has been clearly provided. But all the 3 included RCTs were pooled together but did not justify grouping despite differences in settings, patient comorbidities, and intervention variations. Next, here, Prisma expects to describe methods required to prepare the data for presentation or synthesis. Software and modeling approach has been clearly described, but there is no description about data conversion. Coming to handling of missing summary statistics, pairwise deletion is mentioned, but there is no detailed explanation or sensitivity analysis of the missing data. Third item, here the Prisma expects to describe any methods used to tabulate or visually display the results. And as Divya already mentioned, the methods have been clearly tabulated and flowcharts have been mentioned. The fourth part here, Prisma expects to describe any methods used to synthesize results. The meta-analysis performed is clearly stated. The model is specified. Rationale for model choice, effect measures, heterogeneity testing, threshold, and software, and all these aspects were clearly described. In the fifth part, Prisma expects to describe any methods used to explore possible causes of heterogeneity. Quantitative heterogeneity assessment has been done by I-square and chi-square test. Although only sensitivity analysis has been performed, no subgroup analysis or meta-regression has been done. The last part, here Prisma expects to describe any sensitivity analysis conducted. Sensitivity analysis was conducted only for mortality, composite outcome, and hospital stay. So the next part for here is the reporting bias assessment. Methods of detecting reporting bias has not been described in the study. Next is certainty assessment. the study has discussed several factors affecting confidence like study bias, variability among the results, and sample sizes. So the criteria has been clearly satisfied. Next, coming to the results, it has been described from 16 to 22. First one is the selection process, which has been described in two parts. First one here, it's being discussed about result of the search and selection process. The records were identified, the clear description of records identified and screened, duplicates and exclusion details, and use of flow diagram. The second part here, Prisma expects to cite studies that might appear to meet the inclusion criteria, but which were excluded, and explain why they were excluded. The list of excluded studies were provided, but the list was not given. Just the number was mentioned. The reason for exclusion has been clearly provided, and 5 full text articles were excluded. Coming to study characteristic, each included study has been cited. The study characteristic, key features like design, population, intervention, comparator, and outcomes, and setting and sample size has been clearly mentioned in the results. Coming to risk of bias in the studies, each study's bias has been presented. Independent reviewer assessment and conflict resolution tool used for bias assessment and domains of assessment has been clearly mentioned, satisfying the criterion. Coming to result of individual studies, summary statistics for each group has been presented. Effect estimates has been reported. Precision of estimates has been presented. And their forest plots and summary tables has been provided. Next, coming to the result of synthesis, it's been described in 4 parts. First one, Prisma expects to summarize the characteristics and risk of bias among the contributing studies. It's been described in tables and reported via text and Ravis figure. Second part, here the Prisma expects to present results of all statistical synthesis conducted, summary estimate for each synthesis, precision of estimates, heterogeneity measures, and the significance of effect has been clearly mentioned, satisfying the criteria. The third part, here Prisma expects to present all investigation of possible cause of heterogeneity. Identification of heterogeneity among outcomes has been done. Investigation for the cause of heterogeneity has been done. Presentation of it has been presented in quantitative result, and interpretation of possible causes has also been mentioned, but there is no use of subgroup analysis or meta-regression. The fourth part here, Prisma expects to present results of all sensitivity analysis conducted to assess the robustness of the results, which has been clearly satisfied for the key outcomes. Next one is the reporting bias. Here, Prisma expects to present assessments of risk of bias due to missing results, but there is no assessment of reporting or publication bias mentioned in the results. Next is certainty of evidence. There is no use of structure tool or certainty ratings for each outcome, although discussion of risk of bias and heterogeneity has been done qualitatively. Coming to discussion part, it's been described in 4 parts. First one, general interpretation of the results in context of other evidence, summary of main findings, comparison with previous studies, integration with broader evidence, discussion of possible reasons for differences, and clinical and public health implication has been clearly discussed in the study. Second part, Prisma expects to describe the limitations of the evidence included in the review. As we already said, only 3 RCTs were included, so it has been acknowledged as a major limitation. Only one high bias study was there, that's Chisti et al., and which has been highlighted, and heterogeneity and inconsistency was reported but partially explained. Next is the limitation of the review process. Search strategy was complete. Screening and review process transparency is there. Bias assessment process was done by Cochrane ROP2. Publication bias and selective reporting limitation has also been acknowledged. Although, coming to handling of missing data and certainty of evidence evaluation, which has not been clearly described. Last one. Here the PRISMA expects to discuss the implication of the results for the practice, policy, and future research. Clinical implication, policy implications, future research priorities, and contextual barriers have been clearly acknowledged. So next one is registration and protocol, which has been described in 3 parts. Here the registration first part expects to provide the registration information for the review. Registration platform and number was provided, registry accessibility verified, and it's been clearly reported that the study has been registered with Prospero and the ID was provided. Next part here, PRISMA expects to indicate where the review protocol can be accessed. The article mentions adherence to PRISMA and Cochrane handbook, but does not provide a direct link or access location for the protocol. But the text indicates that the protocol was developed and registered under Prospero, confirming its existence. Next part, here the PRISMA expects to describe and explain the amendments to information provided at the registration or in the protocol. The paper does not mention any protocol amendments or deviation from the registered Prospero record. Next, support. Here, the authors are expected to mention all financial and non-financial support. There is clear declaration of no external funding, which enhances the confidence in the impartiality of findings. Non-financial institutional support has not been detailed. Next is competing interest. The authors have no conflict of interest, which has been described, indicating full transparency. Coming to the last part, that's the availability of data, code, and other materials. Here, if the PRISMA expects to report if these data are publicly available and where they can be found. No analytical code was shared or referenced as to where this can be accessed, but there is the supplementary data are available through the publisher's site, that's Springer. The online version contains the supplementary material. To summarize, although the review met most PRISMA requirements, few methodological gap remains. Heterogeneity reported, but thorough subgroup analysis or meta-regression not done, despite clear differences in settings, population, and outcome definition. It also lacks standardized outcome definitions, incomplete reporting of data, item selection, and no publication bias or great certainty assessment was done. These omissions limit the confidence and generalizability of the pooled results. Overall, while findings are useful, more well-designed RCTs are required to reliably determine the true efficacy of bubble CPAP in severe pediatric pneumonia. Thank you.
Thank you for that excellent presentation, Dr. Kiran. Dr. Ramakutti sir for the expert analysis.
Okay. First of all, as usual, the presentations were excellent. So I want to commend both the person who presented the paper as well as person who analyzed the paper. And with respect to that, I just want to I want to clarify my own doubt, because repeatedly I see that all the junior residents are doing an excellent job of presenting the paper. Do they have any formal training in this, or do they learn this on their own about the the guidelines, the equator, different types of study?
As a beginning, sir, I would like to comment that from the first session itself, we have been discussing regarding the equator site and which type of analysis should be done in each type of study and all the other things which have been done by only the pediatric, only the PGs and of course the mentors. Over to Dr. Akhlaya Nair, and Madam has to tell something because Madam was mentoring regarding the practicing. My sir was asking regarding how they manage this. I think most of the effort is done by the PGs themselves, right? The meticulous presentation of the, preparation of the PPTs, the analysis and all.
Preparations of the PPTs, and we took a little help from our community medicine department for for some of the statistical analysis and others, and some of those we Googled and learned by ourselves. So,
Thank you very
Yeah,
much.
that's
Sam.
right.
Yeah, Akhila has mentored them very well. That is
Yes,
And Dr.
indeed.
Rekha Madam is also there, I think. Dr. Rekha Madam
Yeah,
is also there, I
congratulations
think.
to all of you, including my friend and classmate, Dr. Lalitha. What I want.
no big role for me actually.
But what I want to emphasize is that when we were residents or
Yeah,
those
that's true.
PGs, we knew nothing about research. So I'm very glad to see that people have come up and I mean that is what the way it should be. I mean people should. I mean generally people say that no, people standards are going down. I think that is wrong. I think the younger generation is really, much better than what we were at their stage. So I'm very happy to
That's
see
so great.
one or two small
That's so
points.
great to hear.
Huh?
So great to hear that, sir. Thank you so much, sir.
Yeah,
Just
sure.
continue,
Of
sir.
course. One or two small points. The person who presented the paper, sometimes kept saying that statistically insignificant, which is technically wrong. There is no such thing as statistically insignificant. It's always statistically significant or not significant, because it's a very, very technical term. I don't want to explain all that. It will take a long time. But no, the reason why I say this is that you're all young, and when you go forward in life and some other more serious forums, when you say statistically insignificant, people may not, they might pick holes in that. There is no such thing as statistically insignificant. It can be statistically not significant. It's better to say that statistically not significant. Otherwise, it was excellent. I mean, there is nothing wrong with that. So that is generally generally about the paper. There are two things. One is, as you rightly pointed out, there is nothing much we can conclude from this paper, because after all, they have looked at only 3 studies. After all the exclusions, they came to 3 studies, and the 3 studies did not contribute much. And you just one study stood out, and that I think skewed the whole thing. And so finally, they are not able to say anything except in the one point that doesn't lead to more mechanical ventilation. That's all. So that sense, it is like reporting negative results. When they say that whenever you report negative results, you must have a large enough sample size. So here, I think after all the exclusions, they did not get enough studies. So actually, what our conclusion should be that there were not enough data to support either one way or the other. So we will wait for more studies. So that is exactly what I think you also said. In that sense, this particular study doesn't contribute much, but then I think it gave you an opportunity to learn, or rather, familiarize yourself with all the methodologies and the terms, all those things like forest plot and risk of bias and things like that. So my only role now here is, if anybody has any questions on those things, I can explain. Otherwise, I don't think there's much to say about this. I think you rightly summed up everything.
Yeah.
In
Yes,
your
sir. Yes, that is true, sir. So both the postgraduates and Akhila Madam and the team can queue up with the questions to ask to Ramkutty sir. But before that, I would like to request Dr. Lalitha Madam to comment on the paper, the presentation, and the clinical implications, madam. If anything, madam, if anything is there.
Just I was listening, and I think the presentations were good. Other than that, the content and all, I'm not at all aware of. That is what I said. But I heard them presenting, and I heard
Yes.
I heard them presenting both the slides and little bit of comments. But I think, as I already mentioned, Akhila has done a wonderful work in mentoring them. That's what it is.
Yeah, madam. Dr. Akhila Madam, Dr. Rekha Madam, anything from the mentors to ask to director, regarding the study, Ramkutty sir, anything to ask?
Dr. Anju, can you come in a little, 1 or 2 comments?
Yeah, sure, sir. Sir, anything to add, sir? You are, you want to
Yeah.
yes, sir,
Yeah,
please.
Dr. Anju, I just want to say 2 things. Of course, the statistical part. I also felt 3 RCTs, out of which 2 were not good. Would have been. And finally, the studies have all been outside India, published in an Indian journal. That looks very nice. Now, what surprised me was they compared low flow oxygen with bubble CPAP. Why is it that way? And then they said the mortality is not different. do you mean to say that you will give low flow oxygen to a child and allow it to die without giving high flow oxygen or and then I have seen, I mean, in my practice, we give low flow, then we give high flow, non-rebreathing mask. Nowadays, they give, I mean, many other mechanisms before they ventilate the child. Therefore, how can you say that low flow oxygen mortality and bubble CPAP? Is bubble CPAP at all common? I have never seen it being for pneumonia. I have never seen it being given. I don't know, Dr. Lalita can tell me whether
Yes,
it's
sir.
given in SAT
No, no.
and all that.
We do use, we still, means even in Gokulam, we do use bubble CPAP. Maybe
Yeah,
Akhila
but
can
my question is, how
explain
can you
it.
compare low flow oxygen mortality with bubble CPAP? When you have low flow CPAP, the patient low flow oxygen, the patient is not doing well, you straight away go into high flow oxygen or in a non-rebreathing mask or something, or use some other technology. You will not allow the child to die on a low flow oxygen. Therefore, how was this done? That's my question. And how did this reports come? How did the numbers come for that? And bubble CPAP, because you don't have the machine to give, or because of the cost you give the bubble CPAP?
Akhila, chip
Dr.
in.
Akhila, yeah.
So the study was conducted in very low resource environments that is in Malawi, in Ethiopia and Bangladesh, where in one of the studies actually even there was no physician available to directly oversee the children after administering CPAP. It was done by the nurses and there was no physician, there was not even availability of physician to daily monitor the progress of the child. So whatever they have is low flow oxygen. Advanced respiratory support is not commonly available in those scenarios. And there is also some myths regarding the use of advanced respiratory support, some local myths. So all these were hindrances towards providing advanced respiratory support for some severely sick children. So the significance lies in if at all the child can improve with a bubble CPAP, which is not maybe as expensive or difficult to obtain in these scenarios, the child may, if the baby is surviving, let him.
See, what is low flow oxygen? Low flow oxygen, I think, is 1 to 2 liter of oxygen on the nasal cannula, or maximum you can say 5 liter oxygen on a mask.
Yes.
What did they mean by low flow oxygen? Had they defined it in the study?
Yes, sir. In individual studies, they did define it. In one of the studies, they did mention 1 to 2 liters of oxygen by nasal prongs. The one study from Bangladesh also used low flow oxygen by nasal prongs as well as high flow oxygen by nasal cannula as well as against bubble CPAP. That was the definitions given in the study.
No mask, no non-rebreathing mask was not given, is it? Oxygen.
No, sir. They had specifically used this nasal.
Okay.
Sir, sorry for interfering. Is it something like it is to Ramkoti sir also? What they mean by this sentence, it's low flow oxygen and this bubble CPAP. Is it something that, what they are meaning is it is something? Is it something like a non-inferiority trial thing like that? Because since both are, there is no difference. There is equally better because the mortality is also less with bubble CPAP as the statistics are showing. And I mean the need for ventilator. I mean not the mortality. The need for ventilator is less. So. In that place, actually using a bubble CPAP may be having a bit better advantage. Is it that way of thinking that with their meanings by this sentence that I mean both are equal, rather than thinking about low flow oxygen as a inferior method of treating this thing. While using this bubble CPAP, it has this advantage of preventing mechanical ventilation later. Can we think like that, sir? Ramkoti sir, I'm just asking. Since sir told
I
that.
think this study is basically like they're doing it in a non-optimal environment. They don't have the best.
Yes.
They're trying to compare two inferior modes of treatment. So I'm saying that whether one is better than the other. But I think, as you rightly said, they thought of it as a non-inferiority trial. but I don't know whether you can really say that they have established non-inferiority, because confidence intervals are so wide that my impression is you can't say anything. I mean, like, seems like inconclusive.
But sir, in one of our early sessions, I have asked a question that in a meta-analysis, is there a minimum number of study to use and all? And I remember sir telling that it is very difficult to say, because even if you get a two meta-analysis, I mean studies and all, it is okay to do. I mean,
So that is
is
like
it
what
very? I mean,
what I said earlier. I myself have published a meta-analysis on with Dr. Papachan, who is actually originally from Calicut Medical College, now in UK. He's an endocrinologist. We published a study of just 5 studies, meta-analysis, to see whether growth hormone treatment is necessary. I don't remember the context, and I'm not a clinician.
Yeah.
But they established that it is useful. So when it is a positive result, it is okay. Even if there are only very few studies, positive result means you have demonstrated an effect. So here is a negative result. The negative result with very few is you can't say anything. I mean, that is the problem.
One more thing that Padmanabhan sir has rightly pointed out to Dr. Akhila madam regarding CPAP itself, because we have already established that the significance is more in low-income countries and all. So is bubble CPAP is something which can be indigenously made, or are they mentioning what type of bubble CPAP they are using? Or is it an indigenously made bubble CPAP, or the expensive bubble CPAP machine they have been procuring? Anything, madam? Can you please throw some light on that?
Yes, sir. In the study done in Malawi, they have used the commercially available Fisher and Paykel machine. But in the other 2 studies from Bangladesh and the Ethiopia study, they have used the indigenous, that is with the water in plastic bottle, that technology that was used in the other 2 studies. And it has been actually shown like the Fisher and Paykel, the study with Fisher and Paykel bubble CPAP has shown more of adverse events, whereas the other 2 studies were actually favoring the bubble CPAP.
I think this indigenously made bubble CPAP, there were studies during that time which has established that it is okay to use those type of, I mean, is it like that, madam? I mean, is there any, can we use that indigenously use that bottle bubble CPAP for, I mean, is there any studies showing that it is harmful for the baby? Anything like that, madam?
Most of the studies
Because
have,
in,
it
yes,
could
ma'am.
be, it helps in improving the providing respiratory supports. I'm not aware of any negative studies in that.
Yeah, madam, one doubt I had was regarding the type of pneumonia and the age of the children they were using. Like, what type of pneumonia was where? I mean, as a common clinician as perspective, I'm asking only. In this study, what type of pneumonias were they involving severe pneumonias like staphylococcal with pleural effusion and all those things, or simple pneumonias, Klebsiella or the microsoft? Are they having any stratification like that regarding the CPAP, this study,
No.
this meta-analysis?
They have just mentioned severe pneumonia as per WHO criteria with hypoxemia. They have not
What I
gone
want
into
to mean
the.
is that, are we having any particular criteria? For giving service bubble CPAP. And for example, a patient admitted with pneumonia and all, is there a point at which we take into consideration few aspects and we decide that okay, this is an ideal candidate for bubble CPAP? I mean, is there some already known named studied criteria? Is that available, madam?
So WHO
Anything?
recommends the use of bubble CPAP in those children who have failed to attain, in those children who have hypoxemia despite giving low flow oxygen, to recommends the use of CPAP in improving the respiratory outcomes. And in general, we also use it granting severe retractions and so on. Sir, and one more thing I would like to say.
Okay, madam.
Modalities
Yes,
like
ma'am, please.
HFC are more expensive, even in private sector today. So sometimes in those alternatives, when you opt for a less expensive modality, bubble CPAP can to some extent provide respiratory support.
Okay. One more thing, Dr. Amgadu sir, we have seen that they have eliminated, two studies. That is one McCallum and another study in calculating certain, outcomes and all. So is that actually, recommended? Can we do things like that? My actual question is, what aspect of those studies actually made the, heterogeneity? Was that addressed, sir? So shouldn't we think about that aspect also, sir? Because there are only 3 studies only. So while calculating, we should be taking into consideration whatever statistics is present in all the studies and all. And is it a way of,
Yeah,
getting a data?
that's a little too technical because the test for heterogeneity is very statistical in thinking. I don't know that I can explain all this, but when you use a random effects model, then the assumption is that it's a homogeneous. It all comes from uh, random studies within a group. I don't know how to explain that further, but when you have fixed effects model, you assume that these are different populations. So when the heterogeneity test fails, or rather it says it is heterogeneous, like in this case, which means probably you should have used a fixed effects model, but then you don't have enough numbers to use a fixed effects model. So it's a little complicated. They have done what is necessary, but again, because of the numbers are few, I don't know, because the so-called I-squared and all, it's an indication of heterogeneity, whether the studies are really from different populations or from the same population.
Okay. Regarding the covidence tool they are mentioning, actually, that term has not, we have not dealt with that term in previous studies.
That is new to me also, but I understand that it is a tool for assessing whether comorbidities affect the outcome or something like that. I'm not, because they could not do a meta regression because there are not enough studies again. Meta regression is one where you put the outcome or effect measure as the outcome variable and other variables as your predictor variables and see whether other variables have affected the outcome. No, with 3 studies you can't do much. That is ultimately that is the bottom line in this whole presentation.
Yes, sir. But I think with the
Excuse me.
yes, please.
So this Covidence
Yes.
tool is a software used to manage the screening and the selection process. So it's a software for screening and the selection process of the study. That is the Covidence tool.
Thank you.
Also, Madam is telling something about ROBEL, that visual representation. Could you tell something about that ROBEL and ROBIS?
What is that?
Some visual. ROBEL and ROBIS. They're telling about the visual representation, right? I think the analysis part, Dr. Kiran was telling about.
B2.
Yeah. I think it's a method to represent whatever data which was got in a visual way. That is what I understand, actually, if I'm not mistaken. And as a conclusion, I think from the studies and the discussion, right, the right, if we are trying to give CPAP for indicated children, the requirement for mechanical will those are 2 are the main conclusions that we are having. Sorry, sir. Sorry for that.
No, is the question addressed to me?
Sir was asking something, sir. No. Yeah, that. Yes, sir. Actually, Dr. Kiran, could you just tell regarding that ROBEL, that slide that you were showing now? If you want to, reload the PPT, you can. You want to share the PPT? You can. Dr. Akla, am I audible? Yeah. Are you able to? Yeah. We can go to the analysis part. Analysis part. We can go go to the analysis part. Yeah. I think the slide was towards the end of the presentation. Yeah, go forward, madam. Yeah.
Job 2.
Furthermore, please.
Are you talking
Yeah,
about
yeah.
job 2
Can
is
go forward. You hear the auto. Yes, sir. Here they
job
are showing automation visualization tool regarding RoboVis package for graphical display they are telling. And I think towards the end of the presentations, madam has told regarding Robel. It was a positive point that they have used this. That was what madam was telling actually.
ROB
I
is
was
risk
just
of
wondering,
bias.
sir, what it was actually. Ramgoti sir.
ROB is risk of bias.
So it shows, it visualizes it.
And
So
it will
we have a
show visually
visualization
what
for
is the
the
risk of bias. I
bias.
think
Is
there
it
is a
like that,
chart
sir?
in that paper. If you look at the paper, you will find a bar chart with color codes. Like if it's green, it means there's no bias, like that.
Yes.
I mean, it is not in this one, but if you go to the paper.
Can you go back actually? Paper, sorry. It is not that, traffic light picture, that is different, no? Is it the same one?
I think so. I distinctly saw, there's a bar.
Previous one. Can you go back? Back. Can you go back? Back a little. You had that traffic code picture now. You showed that picture.
Yeah,
actually.
the one at the bottom. Actually, this is in black and white, but I think in the paper.
Yeah, this is it.
Green
this
and
bias.
Yeah, that is right. This is
Red
the
was there. Yellow was there.
Yeah. So which means green means there is no risk of bias. Red means there is bias, like that. So moderate risk, high risk, and so I mean it's actually judgment. Two people judge each paper, and if there is a difference in opinion, a third person comes in and resolves the contradictions. So that is how you.
Yes.
So there are different types of tools. One is the risk of bias tool used by, usually used is the Cochrane risk of bias tool, but there are also other tools like Jadi, some other person's name is associated with the risk of bias tool. So, and this is a way of visually presenting the risk of bias.
Okay, thank you, sir. Because
so whenever you present meta-analysis, you are supposed to say something about the risk of bias. Whether you show it visually, at least you have to say something.
Okay. Anyway, thanks, Dr. Kiran, for presenting this, because Dr. Kiran as well as Dr. Deep, because this type of graphical presentation is first of kind in our General Club and that. So, go to Dr. Rekha Madam is there. Dr. Rekha Madam. Dr. Rekha Madam is there. Dr. Akhled, Dr. Rekha Madam is there. I think Dr. Rekha Madam has left actually. Okay, actually the topic is open for discussion. If anybody has anything to add or contribute, they can. Dr. Patma, sir, any closing remarks, sir?
Nothing. I'm still interested in knowing, certain things like how many deaths were there in both this one, number of deaths. And they said the risk of ventilation is decreased. That means did they do ventilation in some children and later on?
Anything they have mentioned that way? Dr. Divya, have they mentioned anything like that?
There's no mention about like ventilation.
But you said that they decrease the risk of ventilation, in one of the there's no difference in the need for ventilation. How did they come to know about it without doing ventilation? Number one. Number two, the deaths were not different, they have written. So what is the deaths in the low oxygen patients as well as in the patients who were given bubble zipper. That's what. See, nobody can give low oxygen and allow a child to die without increasing it to at least 5 liters of oxygen. If, you can give up to 5 liters with a nasal cannula. Normally, you may give 5 to 10 with a rebreathing mask, and you may give even up to 10 with a non-rebreathing mask. This much at least, basically, you should give. I don't know whether they said that there was no mechanism to those data were not there. Therefore, how did they infer that there was no difference in the mortality? That's what, and the need for ventilation. That's what are my questions.
I
There's
think
no data
they
on
they have showed the statistics as
I
charts
can't hear
that the
you, Manju.
confidence intervals. Sorry, I think they have shown the statistics in the charts, and the confidence interval and the risk ratio, etc. were shown. Is it not like that, Dr. Divya?
Yes, sir, they have mentioned about the risk
Yeah, if you
need
want,
for
you can
mechanical
you can share. Yeah,
need for
you can tell
mechanical
also.
ventilation as risk ratio and the confidence intervals that is mentioned in the study.
Yeah, I
And
think those statistics were taken from the individual studies, and that is how they calculated the confidence interval and the risk ratio. And the
yes, sir.
significance also they have mentioned whether it was significant or not, like
But you know how,
the
if
number
you're
of
not
deaths.
if you're not doing ventilation, how can you find out what's the need for ventilation? I don't know. How did they come to that?
So what I understand is, sir, if in the individual studies, if you go, I think they would have been mentioning the number of patients who are really needing ventilation, and the outcome like getting well and deaths and all. And that statistics was actually pulled into calculating these statistics in the meta-analysis. Is it like that, Dr. Akhila? Am I right?
Some of those children did require ventilation. So once if the
Yeah.
child is not improving with this, I think they went on for ventilation. Not improving with bubble CPAP, they go on for
Yeah.
ventilation. So some of the children did need ventilatory support. One of the studies only mentioned survival to outcome. The other two studies reporting ventilation requirement for ventilation. And so they did ventilate some of the children. And sir, they are in the individual studies, they are saying the use of nasal cannula up to they are specifically saying nasal cannula in all the 3 studies. And in one study in Ethiopia, they have gone up to 4 liters. They are mentioning nasal cannula, sir.
But nobody gave a mask oxygen, is it?
Sir, there is no mention of mask oxygen, but if the child is not improving, they have gone in for ventilation in those children.
Okay, normally we go in from, if there is hypoxia, if there is 3 to 5 liters, it's not going. You give 5 to 10 liters with a mask, non-breathing,
Yes.
rebreathing, and later, rebreathing and later non-rebreathing oxygen. That's how, then only you decide on ventilation. That's the third step. That's what I used to practice. I don't know if there are intensivists now. I don't know how they will do it. But,
Sir, I think regarding the percentage of oxygen which a nasal prong delivers and the mask delivers, it is a bit different. Is it like that? No, Dr. Akhila. And also in small children, actually, they prefer. I mean, the oxygen delivery device will also vary with the age of the child. Also, is it like so? Those things actually determines these things. Anything? Is it like that, Dr. Akhila? Am I right? Right? Anything to contribute?
Yeah, I will contribute here. See, if you give 1 to 3
Yeah,
liters,
sir,
it's
please,
a normal
please.
thing which you give. If you give above that, the nasal mucosa may get injured. But still, in newborns,
Yes,
if
sir.
you tightly keep it over, it will act like a sip-up. It will act like a sip-up if you put it tightly. If you give 3 to, but you can't give it for prolonged period of time. Therefore, that will give you a FiO2 of about 40%, 30 to 40%. If you want to raise it further, you have to give a mask and a non-rebreathing mask with 5 to 10 liter of oxygen. And if you're rebreathing may give up to 50-60%, and non-rebreathing FiO2 15 liters may even give 100% oxygen. That's it.
100%.
But that it is a very costly business because you are wasting so much oxygen on it. I can understand. But nobody can put a child on oxygen low flow oxygen and say this is the mortality in low flow oxygen, because you cannot allow a child to die on high flow oxygen, especially when they have ventilated also. That's my only issue.
Yeah, yeah. Dr. Akila, has it something to do with the, the level of hypoxemia which is already present in the pneumonia child and the oxygen which is given like that? Like you titrate it with the ABG or I don't know. Is it like that only? Because one of the outcome is the, the presence of hypoxemia, which is less in the bubble CPAP. Am I right, Dr. Divya?
Yeah,
Yeah,
yes, sir.
isn't it like that? Yeah, hypoxemia. So
Yes,
that means
hypoxemia is
that
one of
the oxygen that we are giving is actually at a stage where the patient has not gone in for hypoxemia. It is a much early stage, right? So at that point, whether the amount of oxygen that we should be delivered should be very high or not, Dr. Akila or Dr. Rekha, anything to comment on that?
Maybe they have looked into other factors like the work of breathing, which maybe cannot be entirely dealt with maybe oxygen, high flow oxygen. Also, maybe the child needed other respiratory supports, maybe more invasive ones. Maybe once the child is not improving, they have gone in for that. And one of the studies, like I said, the children were not monitored by doctors on a daily basis. So they were not at all having any advanced facilities. So those children
Mhm.
have succumbed to that. The study in Malawi, they did say that the children were not monitored by physicians on a daily basis. So maybe those were the conditions which are had explained, and the need for maybe in those areas where the facility was available, once the child is not improving, they might have taken the child out of the study and gone in for further interventions as needed. So I think maybe individual, this is what I understood
Yeah.
from reading from the individual studies.
Okay. Anyway, that is an important point that Sarah pointed out. And Dr. Rekha, madam, anything to contribute? Dr.
I'm
Rekha,
so
madam?
excellent presentation and discussion. I was listening to the
Yeah,
presentation
no
as
doubt
half the
about
time
that.
I was driving. Um, this time the effort was entirely by the PGs and the mentor, Dr. Akila. So I think they've done a wonderful job. We chose this mainly not for the content of the study, but usually all the times we have been doing RCT. So we wanted to do something different and analyze a systematic analysis. So we do understand the lacunae in the study regarding the bubble CPAP, and Anju had also raised that issue. So, but we decided to go ahead, and I think it was a fruitful discussion. Thank you.
Thank you so much. There is no doubt about the point that the presentation as well as the efforts put in were excellent and beyond comparison. No doubt about that. But the basic idea of Journal Club is regarding the discussion which actually comes up, which really deals with the lacunae of the studies. Because throughout the Journal Clubs, we have seen that no, the studies are having, all the studies may be having, which come from the big journals. The titles may be very attractive and all, but when we analyze and discuss, we understand that most of them are having. So that discussion is the most important thing, and in that way, I think this was a very excellent discussion. And both Akila Madam, Kiran, and Dr. Divya were answering questions and contributing to the discussions in a very fruitful way, actually, because most of the questions raised were very pertinent, and it was an excellent discussion and experience, no doubt about that. And
Suggestion,
especially thank
Anju, I just want to say something. Like maybe we could do something in the coming journal clubs. We could give them a hint as to what type of study they have to select. So, because that will make it a little more easier for the people. What type I meant was, do we take an RCT this time or do we take a systematic analysis? Because RCT either ways, last time they had discussed the whole thing. So the same thing would be repeated otherwise. So that is why I said some hints as to and select a study with these things, which probably Sir can also help with us, because otherwise it's little difficult to select each time a study, and that is why these confusions regarding the studies do happen. Just a suggestion.
please. Actually, yeah, that is a point which is well taken. We will definitely think about that. Actually, Padma sir and myself was also discussing on the same thing actually to make it a bit more specific and to focus the topic on particular things. All those things we will definitely take into account. And thanks for that great suggestion. We will definitely take into the account that. But please don't be such discussions. And what what we usually think is the comfort zone of the presentators as well as the mentors are that also we take into account. And most of the time we before presenting a lot of articles will be discussed actually, and we eliminate and consider, and we sometimes rework. All those things happen most of the time, but that point is well taken. Thank you so much, Rekha madam. Anything more from the
See, Anju, the point is that statistically analysis is also important, but the subject, the clinical interest of the subject is also very important. Whether it impinges the practice of the pediatricians in general, not if it impinges on the practice of highly specialized places, the general pediatricians may not be very interested in it. In fact, I will not be very keen to look into that subject. But we have so many articles which I have sent it to you also.
Yes,
recently, WHO has published many research meta-analysis on the role of aminophylline in acute asthma, role of magnesium sulfate in acute asthma, role of IV beta. They have written beautiful publications that have come on that. There's been a very good study in the New England Journal on malnutrition, IV fluid therapy, and editorial on that. Therefore, these things directly impinges on the practice which we do day to day. And therefore, that also is important, I think. The subject is also
definitely. Your point is very correct, sir. The subject is very important, actually. But a few points I would like to tell since the point was brought up. First thing is that, sir, your article was also being discussed, actually. And second thing is the accessibility to, there is journals. Some of them are paid and all, and only institution-wise accessibility, if it was there, and that has been well taken into account, and the advantage of that was taken. That would have been of very help to the journal club actually, and I don't know how to what extent it is possible in various institutions and all. And the third,
which were not accessible, I sent you the journals.
Yes. Yeah, sure, sir. And also the third thing is that we usually go to, I send a long list of commonly, common topics like asthma, pneumonia, upper respiratory tract adenoids, and all those things. But sometimes we will have to go a little deep. For example, sometimes we decide to take a cardiology case or a neurology case, and sometimes they come in with an interesting but a bit deep. In between, we go for that also, sir. But the point is well taken, sir, actually. Thank you so much, sir. So, sir, the time is already a bit late. So, yeah. So it was a great discussion, and I first of all I thank Dr. Rekha madam for the support madam is giving and coming up, and Dr. Akhila and Dr. Rekha madam for coming up with this beautiful article, and it was worth the discussion, which is very important in public health aspect as well as the tertiary care aspect, and Dr. Akhila madam for mentoring and for the discussion. Dr. Kiran for analyzing it excellently, and Dr. Divya madam for presenting it excellently. And from Ramakuti sir, sir is telling thanks to him for a useful discussion. Dr. Ramakuti sir was a bit busy today, but he managed to come. That is, thanks to sir also, and Dr. Ekha madam. And we had the privilege of having Lalita madam also with us. So heartfelt thanks. Thanks from our heart. Also, Dr. Pratnama sir, coordinator, and all those who have joined us. Is Dr. Srijit sir there? Dr. Srijit? Yeah, I think Dr. Srijit sir is a little busy today with the upcoming Pedicon and all. So once again, thank you, and we'll call it a day, and have a great time ahead. If nothing else is there, we can call it a day.
Great time in the conference, pediatric conference.
Thank you. Thank you, sir. Thank you. Thank you very much. Okay, ma'am.
Thank you, sir.
Thank you, sir.